ચાલે
નહીં ચાલે ચાલે ગુજરાતી મારી
ચાલે
માસી
ને.
છે.
બસ તો
I was very tempted to do my talk in Marathi or Hindi today, but I didn't have the courage to do it. Next time, sir, नक्की sir, next time मी करेन.
नेक्स्ट टाइम सर्जिकल ओपिनियन इन मराठी हिंदी गुजरातीમાં
व्हेरी गुड.
मराठीमध्ये करेन मी नेक्स्ट टाइम.
हा इफ यू कॅन लर्न फॉरेन लँग्वेजेस देन यू कॅन.
मॅडम तुम्हाला दिसते माझी पीपीटी?
हो 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 स्मिता, यू कॅन मराठीतच बोल आणि सुरुवात कर.
ओके. फर्स्ट ऑफ ऑल मी इंट्रोडक्शन देते. त्याच्यामध्ये ऍक्च्युअली आय एम लुकिंग आफ्टर वेक्टर बॉर्न अँड कम्युनिकेबल बेसिकली विच कम्स वेक्टर बॉर्न विच कम्स अंडर कम्युनिकेबल डिझीजेस. आय स्टार्ट विथ मलेरिया. मी मलेरिया पासून स्टार्ट करते. मलेरिया इज
फुल स्क्रीन करा. फुल स्क्रीन म्हणजे तो एक आवर ग्लास सारखा पेल्यासारखा क्लिक असतो खाली उजवीकडे स्क्रीन त्याला दाबलं की फुल स्क्रीन होईल तुमचं. स्लाइड मोठी होईल म्हणजे नाही केले तरी चालेल. आहे ते बरं आहे. चला
चालेल नो प्रॉब्लेम.
करा करा. नाही असं आहे तसं चांगलं आहे मॅडम करा.
रीड करता येते ना सर? मी सगळ्यांना दिसते ना प्रॉपर?
हो हो.
It is one of the major public health problem in India as we are having so many malaria cases. आपल्या BBCMC jurisdiction मध्ये मलेरियाचे केसेस भरपूर आहे कारण की वी आर लाइंग इन बाउंड्रीज ऑफ मुंबई. बेसिकली मुंबईला मलेरिया, डेंग्यू हे जे वेक्टर बॉर्न डिझीजेस आहेत हे भरपूर प्रमाणात आहे कारण की तिकडे इन्फ्रास्ट्रक्चर जास्त डेव्हलपमेंट आहे. तर म्हणून मग आपल्याकडे मायग्रेटरी असल्यामुळे वी हॅव मोर ऑफ मलेरिया केसेस. In spite of knowing positive organisms effective and simple, okay fine, greatest concern they should, okay आपल्याकडे मलेरिया कोणताही पेशंट सकम नाही झाला पाहिजे. बेसिकली हे सगळ्यात म्हणजे हे सगळ्यात इम्पॉर्टंट एम आहे सध्यासाठी आपलं. व्हॉट इज बेसिकली मलेरिया? It is a vector-borne disease. Its agent is Plasmodium vivax and Plasmodium falciparum. हे दोन जे एजंट्स आहेत ते बेसिकली आपल्या एरियामध्ये आपल्याला ह्याचे केसेस भेटतात आणि बाकीचे जे आहेत दॅट दोज ऑल केसेस वी डोंट फाइंड ओव्हर हियर. वेक्टर म्हणजे मस्किटो. It is an infected female Anopheles mosquito. Spread is through the bite of mosquito. The vector breathes in clean and stagnant water. We all know that की हे जे मस्किटोज असतात हे स्वच्छ पाण्यामध्येच ब्रीड करतात. गटरच्या पाण्यामध्ये नाही करत. गटरच्या पाण्यामध्ये क्युलेक्स मस्किटो ब्रीड करतो विच इज फॉर फायलेरियसिस. सो बेसिकली मलेरिया जे आहे ते स्टेग्नंट क्लीन वॉटर आहे त्याच्यामध्ये मस्किटो ब्रीड करत असतो. Causes of malaria I'll talk about. Malaria is caused by the bites of female Anopheles mosquito, which infects the body with the parasite Plasmodium. This is the only mosquito that can cause malaria. The successful development of the parasite within the mosquito depends on several factors, being temperatures. When an infected mosquito bites a human host, the parasite enters the bloodstream and accordingly in the liver. For the next 5 to 16 days, it will show no symptoms, but later on it will start multiplying asexually and then the symptoms starts generating. The new malaria parasites are then released back in bloodstreams. They infect the red blood cells and again begin to multiply. Some malaria parasites, however, remain in the liver and not released till later, resulting in recurrence. म्हणजे आपल्याकडे जे relapses होतात जे cases, that is due to that malarial parasite which remains in the liver and again relapse होतो म्हणजे परत त्या व्यक्तीला again and again मलेरियाचं हे होतं, infection होतं. Clinical pictures, it's a periodic fever, rigor stage, hot stage and sweating stage. Basically there is splenomegaly, anemia आणि ल्युकोपिनिया हे जास्त प्रमाणात असतं. Prodromal symptoms, basic symptoms त्याच्यामध्ये muscle pain, headache, anorexia, malaise. Atypical symptoms मध्ये cerebral malaria, alert ते सगळे further stages आहेत. बेसिक सिम्पटम्स मध्ये जाऊ आपण. मॅडम आय एम गोइंग अ लिटल फास्ट बिकॉज हे सगळं ऑलरेडी आपल्या ह्याच्यामध्ये आहे. इज इट ओके?
येस ओके स्मिता.
सिम्पटम्स ऑफ मलेरिया जे आपल्याला क्लासिकल सिम्पटम्स दिसतात पेशंट्स मध्ये, फीवर विथ चिल्स हे सगळ्यात इम्पॉर्टंट सिम्पटम आहे मलेरियाच्या पेशंट मध्ये. हेडेक, फटीग, पेन, नॉशिया, वॉमिटिंग, एनलार्जमेंट ऑफ स्प्लीन, ड्राय कफ हे खूप कमी प्रमाणात दिसतं बट समटाइम्स some patients are having that. Test and diagnosis of malaria, it is very non-specific. मलेरिया इज क्लिनिकली सस्पेक्टेड ऑन द बेसिस ऑफ फीवर. येस, आपण फीवर कोणता पण पेशंट फीवरचा असला किंवा फीवर विथ रायगर्स किंवा चिल्स सांगत असेल तर वी सगळ्यात प्राईम सस्पेक्ट वी आर ऑलवेज सस्पेक्टिंग दॅट पेशंट कुड बी ऑफ मलेरिया. There is no combination of symptoms. Peripheral सगळ्यात इम्पॉर्टंट डायग्नोसिस साठी टेस्ट इन्व्हेस्टिगेशन जे आमच्या UPSCs आणि हॉस्पिटल्स मध्ये होतात, तर पेरिफेरल ब्लड स्मिअर पॉझिटिव्ह असेल तर तो पेशंट कन्फर्म मलेरिया पॉझिटिव्ह असतो. रॅपिड डायग्नोस्टिक किट जे असतं RDK पॉझिटिव्ह, दॅट इज नॉट कन्फर्मेटरी टेस्ट ऍज पर द गव्हर्नमेंट प्रोटोकॉल. म्हणून आपल्याकडे सगळीकडे पेरिफेरल ब्लड स्मिअरच घेतला जातो. त्या पेशंटचं आपण नोटिफिकेशन आपण गृहीत धरतो दॅट इज अ मलेरिया केस. RDKचा जरी आमच्याकडे पेशंट असेल तरी आम्ही त्याचा स्मिअर परत रिपीट करून अकॉर्डिंगली आम्ही त्याचं कन्फर्मेशन करून घेतो. कंट्रोल ऑफ मलेरिया, इट इज कंट्रोल ऑफ मलेरिया आपल्या वसई विरारमध्ये बेसिकली हे सगळीकडेच नॅशनल सेंटर फॉर वेक्टर बॉर्न डिझीज कंट्रोल प्रोग्राम मार्फतच हे सगळा कंट्रोल आपला चालू आहे. ह्याच्यामध्ये दोन प्रकारचा कंट्रोल येतो. वन इज पॅरासिटिक कंट्रोल अँड वन इज वेक्टर कंट्रोल. पॅरासिटिक कंट्रोल म्हणजे पॅरासाइट्स कंट्रोल करायचं आहे. दॅट इज ऑल्सो डन बाय द सॅनिटरी डिपार्टमेंट. बट मेडिकल हेल्थ डिपार्टमेंटमध्ये जर आपल्याला सगळ्यांना माहित असेल की आपल्या ANMs, आशाज आणि मल्टीपर्पज वर्कर्स MPW त्यांच्या मार्फत सर्व्हिलन्स मध्ये होतो. आणि वेक्टर कंट्रोल मध्ये येतं आपलं सॅनिटरी डिपार्टमेंट. सॅनिटरी डिपार्टमेंट थ्रू आपण स्प्रेइंग, फॉगिंग हे सगळं करतो, इनडोर आउटडोर. अकॉर्डिंगली आपण वेक्टर कंट्रोल करतो. This is the larva. This is the Aedes and Anopheles larva, and there you could see the mosquito breeding also. That mosquito is Aedes aegypti, which is for dengue. Parasitic control madhe, basically she was having fever since 3 to 4 days, and she had gone to some private practitioner. She was basically from Nalasopara East. ती गेलेली तिकडे आणि fever with लूज मोशन्स होतं तिला. तर the doctor treated her for loose motions and fever आहे, but he thought it is probably something due to loose motions or something. He gave her symptomatic medicines. Again her fever subsided a little, but the fourth day तिला भरपूर fever आला and she went into directly gasping state. She was taken from here to Mumbai. It was some Sunday, I guess, because I don't remember it clearly. And she was diagnosed with dengue with some around platelet count was 20,000, and she succumbed. So that was the case की early diagnosis हे खूप important आहे. Fever ची कोणती पण केस असेल तर फर्स्ट ऑफ ऑल हे मलेरिया आणि डेंग्यू ह्याचा दृष्टिकोनाने आपण जर विचार केला तर आय थिंक इट विल बी बेटर अँड द डायग्नोसिस विल ऑल्सो बी अर्ली. इन केस टेस्टिंगचा इश्यू असेल तर यू कॅन सेंड दिस पीपल टू आर UPSCs. और आता डेंग्यू टेस्टिंग साठी आमच्याकडे कन्फर्मेटरी टेस्ट सेंटिनल सेंटर एलायझा टेस्टिंग साठी ओपन झालेलं आहे. 2017 पासून आहे. दॅट इज डुईंग एलायझा टेस्टिंग फॉर डेंग्यू अँड इव्हेंच्युअली वी विल ऑल्सो बी स्टार्टिंग लेप्टो ॲज सून एज आमच्याकडे जे किट्स आहे लेप्टोस्पायरोसिस साठी ते अवेलेबल झाल्यावर वी विल स्टार्ट लेप्टोस्पायरोसिस टेस्टिंग ऑल्सो ॲज अँड वेन रिक्वायर्ड. कारण की एलायझा इज द कन्फर्मेटरी टेस्ट. Okay.
So, Smita, yeah, 1 minute. Please tell us what sample to take and send. So, for malarial parasite, for malarial smear, we have to take a CBC bulb. And what about leptospirosis and for dengue?
No, ma'am, you can send lepto patient to. You can take his blood sample and send it to our hospital.
So a plain bulb for lepto and this, or a CBC bulb?
Yes, ma'am.
No, okay, maybe I'm not audible. No.
नाही कुठे कुठे पाठवायचं असं 17 सेंटर आहे की एकच सेंटर आहे?
काय बोलतात मॅम? परत मला तुमचा क्वेश्चन ऐकून आला.
ब्लड कुठे पाठवायचं आहे? एकच हॉस्पिटल आहे की ऑल?
तुळींज हॉस्पिटल जे आपलं तुळींज हॉस्पिटल आहे ना सर, नालासोपारा ईस्टचं, आपल्याला तिकडे पाठवायचं.
बरं,
ओके 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 ओके. स्मिता, कंटिन्यू.
बट म्हणजे आपण जे कोल्ड चेन मेंटेन करून पाठवावं लागेल अकॉर्डिंगली. त्याच्यानंतर आय कंटिन्यू वन्स. जे पण फिवर केसेस आपल्याकडे स्मिअर घेतात आपण त्यांना क्लोरोक्विन स्टार्ट करतो. फॉर एक्झाम्पल आपल्याकडे फिवर केस त्याचं आपण ब्लड स्मिअर घेतलंय पण आपण त्याला त्याच दिवशी क्लोरोक्विन स्टार्ट करून टाकतो. ओके. अँड आफ्टर रिसीव्ड अ blood smear report based on the species, treatment to be given as per national drug policy. So this is basically the national drug policy of 2010, which we are following now also. Its basic aim is providing complete cure for malaria, prevention of progression of uncomplicated malaria into severe malaria, and thereby reduce malaria mortality, prevention of relapses by administration of radical treatment, interruption of transmission of malaria by using drug, preventing development of drug resistance by rational treatment of malaria cases. ठीक है. Treatment of uncomplicated malaria. All fever cases should be investigated for malarial parasite and full dose of chloroquine to be given. After the report after receiving the report of P-Vivax, we have to start with chloroquine and then tablet primaquine also for 14 days. And for Plasmodium falciparum, we have to start with ACT kit. For the mixed infection, we have to start with the ACT kit and also give tablet primaquine for 14 days. This is as per the drug policy protocol.
What is ACT?
Now this is the treatment in detail. Yes, ma'am.
What is ACT?
Artemisinin combination therapy, ma'am.
Okay, okay.
Treatment of uncomplicated Vivax cases. This is as per the age band which we have given it over here. त्याच्यामध्ये आपण chloroquine ची 25 milligram per kg body weight चा divided dose देतो 3 days साठी. आणि 10 mg per kg म्हणजे हे एज बँड नुसार आहे. लेस दॅन 1, हाफ, 1/4, 1 to 4, 1, 1/2, 5 to 8, 2 to 1, 9 to 14, 3, 3, 1.5, 15 and above 4, 4, 2. आणि तसंच प्रायमाक्विन पण आपण एज बँड नुसार देतो पेशंट्सला. This is uncomplicated. हे falciparum cases ट्रीटमेंट आहे. What you were asking, ma'am? Artemisinin based combination therapy. त्याच्यामध्ये आर्टिसिनेट असं 4 milligram per kg body weight for 3 days plus sulfadoxine 25 milligram per kg body weight. Pyrimethamine 1.25 mg per kg body weight on the first day. And then this is as per the खाली दिला madam, it is as per the age band. Less than 1, 1 to 4, 5 to 8, 9 to 14 and 15 and above. आपल्याकडे first day, second day and the third day. How are we giving all the drugs in divided doses?
Smita, in practice,
Treatment.
We are giving artesunate, artemethin and lumefantrine. We are not given sulfa and pyrimethamine.
They are given that is as per on the first day, na ma'am. Sulfadoxine and pyrimethamine.
तुमच्याकडे आहे का RH मध्ये VVCMC ला हे औषध अवेलेबल आहे का? सल्फाडॉक्सिन पायरिमिथामाइन.
Yes sir, अवेलेबल आहे सर VVCMC मध्ये औषध. पण आपल्याकडे फॅल्सिफिरमच्या केसेस नाही आहेत सर. तर पण ऍज अँड व्हेन आपल्याकडे असतात आपण हेच ट्रीटमेंट प्रोटोकॉल फॉलो करतो.
ओके.
येस.
Okay, Smita, go ahead.
Yes, ma'am. Yes, ma'am. Treatment of uncomplicated falciparum cases in pregnancy. त्याच्यामध्ये as per government guideline, we have to give them quinine salt 10 mg per kg 3 times a day for 7 days in their first trimester, and second and third trimester ला आपण ACT देऊ शकतो as per the dosage which was shown in the previous slide. Accordingly, we can treat them. But it is only shown that ACT is not to be given in the first trimester of pregnancy. Hence, we are giving them quinine salt. All mixed infections, treatment of uncomplicated mixed infections, which includes P. vivax and P. falciparum. All mixed infections should be treated with full course of ACT and primaquine 0.25 milligram per kg body weight for 14 days. Okay, when to suspect resistance, in spite of full treatment with no history of vomiting, diarrhea, and if the patient is not responding, both clinically and parasitologically, then think of resistance. If resistance is suspected, you can treat with oral quinine with tetracycline or doxycycline, or else refer the patient to the hospital setup for further treatment. Other control measures त्याच्यामध्ये अजून येतं मॅडम पॅरासायटिक कंट्रोल. पॅरासाइट कंट्रोल मध्ये आपल्याकडे सर्व्हिलन्स ऍक्टिव्हिटीज असतात, परत ट्रीटमेंट टू क्लिनिकल मलेरिया केसेस, ब्लड स्मिअर एक्झामिनेशन आणि रॅडिकल ट्रीटमेंट ऍज पर द ड्रग पॉलिसी, रिपोर्ट अँड अनालिसिस ऑफ मलेरिया इंडिकेटर्स. ह्याच्यामध्ये सगळ्यात इम्पॉर्टंटली हेल्थ वर्करचा रोल. हेल्थ वर्कर्स म्हणजे मॅडम आमच्याकडे म्हणजे वी हॅव आर ANMs, आशा अँड MPWs हू आर वर्किंग इन फील्ड. हे सगळे आमचे फील्ड वर्कर्स आहेत. त्याच्यामध्ये त्यांचं फील्ड ऍक्टिव्हिटीमध्ये त्यांचा पूर्ण 15 डेजचा एक टाइम टेबल असतो. त्याच्यामुळे त्यांना 15 डेज मध्ये हाऊस टू हाऊस सर्व्हिलन्स ऍक्टिव्हिटी करायची असते. पर डे दे आर कम्प्लिटिंग 50 हाऊसेस. एव्हरी डे दे हॅव टू कम्प्लीट 50 हाऊसेस. त्याच्यामध्ये ते लोक सगळे कंटेनर सर्व्हिलन्स करतात. परत हिस्ट्री घेतात की त्यांना काही फीवर आहे का, फीवर हिस्ट्री आहे का. परत जर कंटेनर सर्व्हिलन्स होत असेल तर कंटेनर सर्व्हिलन्स मध्ये त्यांना कोणतं पॉझिटिव्ह कंटेनर भेटला की ज्याच्यामध्ये ब्लीडिंग असते तर तशा कंटेनर मध्ये दे आर ऍडमिनिस्ट्रिंग टेमिफॉस, जे अँटी लार्वल केमिकल आहे, इफ दे आर फाइंडिंग एनी पॉझिटिव्ह कंटेनर. तसंच हेल्थ एज्युकेशन पण देतो आपण. ड्राय डे फॉलो करतो कारण की आपल्याकडे VBCMC ज्युरिस्डिक्शन मध्ये देयर इज मोर ऑफ चॉल्स भरपूर आहेत, स्लम्स भरपूर आहेत, ज्यांचे मोठे मोठे कंटेनर्स असतात. वॉटर स्कार्सिटीमुळे ते लोक पुन्हा स्टॉक करून ठेवतात बाहेर. तर तसे कंटेनर्स जे असतात आपण तिकडे रुटीन आपला तिकडे ऍटलीस्ट वीक मधून एकदा आपण तिकडे चेक करून मग जर असं काही पॉझिटिव्ह कंटेनर असेल तर आपण त्याला केमिकल जे टेमिफोज आहे ते आपण त्याच्यामध्ये ऍडमिनिस्टर करतो. तसंच फीवर पेशंट असेल ब्लड स्मिअर घेतो. ड्राय डे फॉलो करायला सांगतो. ड्राय डे इज व्हॉट? ड्राय डे म्हणजे एका पूर्ण कोरडा दिवस पाळा आपण म्हणतो. तर कोरडा दिवस म्हणजे पूर्ण आठवड्यातून एक दिवस आपल्याला सगळे जे कंटेनर्स असतात ते आतमधून धुवून व्यवस्थित स्वच्छ त्यांना ड्राय करून मग परत त्याच्यात पाणी भरायचं. दिस इज बेसिकली टू ब्रेक द मस्किटो सायकल. तो 7 डेजचा असतो. कधी कधी वी आर जस्ट थ्रोईंग द कंटेनर वॉटर, तर मग त्याच्यामध्ये तो लार्वा तसाच असतो. तर ते धुवून पुसून परत वाळवून यूज करणं म्हणजे आपण तो लार्वा नष्ट केलेला आहे. सो दॅट वे कोरडा दिवस पाळायला आपण बोलतो. IEC ऍक्टिव्हिटीज करतो आपण. IEC ऍक्टिव्हिटीज मध्ये मॅडम आपण डिस्प्ले करतो पोस्टर्स, बॅनर्स, परत हँडबिल्स वाटप करतो. आपण स्कूल्स मधून स्टुडंट्सला इनिशिएटिव्ह आपण त्यांना स्कूल्सला कोऑर्डिनेट करून त्यांच्या इनिशिएटिव्हनी रॅलीज पण परफॉर्म करतो हेल्थ एज्युकेशन साठी, मलेरिया, डेंग्यू ह्या डिझिजेस साठी. परत पिक्चर कॉम्पिटिशन्स ठेवतो, एसे कॉम्पिटिशन्स ठेवतो स्कूल्स मध्ये. कारण की एक 2-3 months बॅक वी वर हॅव्हिंग दिस मलेरिया प्रोग्राम डेज ऑल्सो इन एप्रिल. तेव्हा स्कूल्स बंद होते, बट असेच एरवी स्कूल चालू असल्यावर आपल्याकडे ते ड्रॉइंग कॉम्पिटिशन, परत एसे रायटिंग कॉम्पिटिशन अबाउट मलेरिया अँड देन गिव्हिंग देम सम प्राइज, हे सगळे आपण मोटिवेटिंग गोष्टी आपण IEC साठी करत असतो. रोल ऑफ द मेडिकल UPSC मेडिकल ऑफिसर. हे UPSC मेडिकल
IEC
इन्फॉर्मेशन एज्युकेशन. हा मॅम.
Yeah, what is IEC?
Information and education, ma'am.
Okay.
Okay. UPSC medical officer असतो. त्याच्यामध्ये he is the first one to come in contact with the community and the community also and the patient also. He is the link between the health post staff and surveillance staff and the dispensary staff. म्हणजे बेसिकली UPSC त्या कार्यक्षेत्राचा UPSC मेडिकल ऑफिसर आहे. ऑल द हॉस्पिटल्स जे पण त्यांच्या ह्याच्यामध्ये ज्युरिस्डिक्शन मध्ये लाय करतात, यू कॅन कोऑर्डिनेट दॅट UPSC मेडिकल ऑफिसर इन केस देयर इज एनी इश्यू और नोटिफिकेशन और यू सीन एनी क्लस्टर ऑफ केसेस किंवा तुमच्याकडे एका एरियामधून स्पेसिफिक फीवर केसेस. मॅडम फीवर नोटिफिकेशन होत आहेत ना आपले?
हो. Yes,
fever cases are being notified. कारण की fever cases notification मध्ये त्याच्यामध्ये सर्व्हिलन्स पार्ट खूप मोठा असतो मॅम. मलेरिया, डेंग्यू केसेस पण जेव्हा नोटिफाय होतात तेव्हा बेसिकली आपण त्या पेशंट्सच्या म्हणजे पेशंटच्या आजूबाजूचे 50 हाऊसेस असतात, आपण तिकडे सर्व्हिलन्स करतो आणि फॉर एक्झाम्पल जर तिकडे हे इन्फेक्शन झालंय त्या कन्सर्न पेशंटला, इट शोज दॅट देर मस्ट बी ब्लीडिंग समवेअर, किंवा मग त्याची डिटेल हिस्ट्री घेतो. हिस्ट्रीवरून आपल्याला समजते की हा ट्रॅव्हलिंग होतं ह्याचं इथे, किंवा त्याच्या घरीच ब्लीडिंग सापडतं. नोटिफिकेशन पार्ट ह्यासाठीच इम्पॉर्टंट आहे की आपण ती चेन आहे मग ती तिकडे ब्रेक करू शकतो आणि जास्त केसेस तिकडे अजून नाही झाले, आउटब्रेक नाही झाला पाहिजे. आउटब्रेक प्रिव्हेंट करण्यासाठी आपलं नोटिफिकेशन हा खूप व्हायटल रोल प्ले करतो. दॅट इज इट मॅम.
But Smita, आमच्याकडे I have never seen any A&M staff or any आशा वर्कर coming to see or check. म्हणजे ते येतात फक्त फवारणी करून जातात. So that is for the vector control, but parasite control आणि ते बाकी सगळं not parasite control but even A&M staff जी हे घेते, we have not had any of them. स्मिता आवाज येत नाही.
ओके, तुमच्या एरियामध्ये नाही आलेत का मॅम? असून
नाही.
पीपल आर इनटू ओनली कोविड तेव्हा असू शकतं, पण
Yeah, your voice, you can stop sharing if you have finished, so then yeah Smita, thank you so much.
yes, I'll stop sharing.
Yeah.
No.
या हेमंत, तुम्हाला काय विचारायचंय का?
आता तुमचा चेहरा दाखवा, स्मित बघू द्या सगळ्यांना. आम्हाला कळलं ना आम्हाला कोण शिकवतो, टीचर कोण आहे. थँक्यू म्हणायला.
येस,
काय झालं?
यू हॅव टू शेअर युअर व्हिडिओ.
व्हिडिओ चालू करून द्या. आता काय स्लाइड्स नाही ना, त्यामुळे.
सर मला ना इट इज बिकॉज ऑफ द माइक सिस्टम इज पुअर ना, मला वाकून लागतंय.
बरं जाऊ दे,
व्हिडिओ ऑन करते पण मला वाकूनच बोलावं लागतं.
जाऊ दे, असू दे, काय नाही काय करू, असू दे.
हा,
मला काय सांगायचं तुम्हाला की तुम्ही जी शाळा 30 लाख लोकसंख्येला तुम्ही कठीण काम आहे तुमच्याकडे. 30 लाख लोकांना येतो का आवाज माझा?
हो.
30 लाख लोकांना आयईसी करायचं एवढं कठीण काम आहे. मग त्याला जेवढं बजेट हेल्थ डिपार्टमेंटला ना तेवढं आयईसी ला पाहिजे, असं माझ्या नावाने सांगा, तुम्हाला सोपं होईल. गेला का आवाज? येतो का
तुम्हाला?
माझा आवाज येतो का तुम्हाला? 30 लाख लोकांना आयईसी द्यायला तुम्हाला बजेट जास्त पाहिजे. जेवढं आईस म्हणजे बर्फ आयसी काय आयईसी ना तुम्ही सांगितलं? आय म्हणजे इन्फॉर्मेशन, ई म्हणजे एज्युकेशन, सी म्हणजे कम्युनिकेशन. अजून काय आहे?
बेसिक आयसी का आपण?
बरं असू दे. माझा आवाज येतो का तुम्हाला? अच्छा,
आयसी बद्दल
व्हिडिओ बंद कर, चालेल.
तुमचा व्हिडिओ बंद करा.
बँडविड्थ वाढेल.
व्हिडिओ बंद करा.
करेक्ट. हो,
तुमचा व्हिडिओ बंद करा, मग ऐकता येईल तुम्हाला.
माझा येतोय पण तो थोडासा ना तुमचा आवाज मला नेटवर्क इश्यू.
आवाज येतो
मला काय?
हा, माझा आवाज येतो का तुम्हाला?
हो.
आपल्या वसईपुरती एवढी बदल.
सर तुमचा आवाज येतोय मला.
माझा आवाज येतो ना?
येतोय सर तुमचा आवाज.
वसईपुरती एवढी बदल करा, तुमची आपली जी नॅशनल आणि ग्लोबल रॅशनल मलेरिया थेरपी आहे ना, ती इररॅशनल आहे. आपण 400 आजारांना औषध करतो ना, कुठे अटी नाही टाकलेल्या की तुम्ही छाती दुखते का, ईसीजी काढा, त्याच्यामध्ये खराब आला तर सॉर्बिट्रेट द्या, असं कुठं नाही आहे. टायफॉइड झाला का कल्चर दाखवा, नाही तर द्यायचं नाही मेडिसिन, असं कुठं नाही आहे. निमोनिया झाला का कल्चर दाखवा, मग अँटीबायोटिक द्या, असं कुठं नाही आहे. तुम्ही प्रायमॅक्विनला अट टाकल्यामुळे मलेरिया हा कधीच 75 वर्षापूर्वी जायला पाहिजे, तर तो गेलेला नाही आहे. कारण आम्ही सगळ्यांना प्रायमॅक्विन देत नाही, मग मेल फिमेल मरत नाही, म्हणून आमचा मलेरिया बंद होत नाही. मलेरिया डायग्नोज केला की त्याला कम्प्लीट क्युअर द्यायला पाहिजे. मलेरियाची दुसरी अडचण अशी आहे की तुम्ही तुमचा दोष नाही, हा इंग्रजांचा दोष आहे. त्याला कम्प्लीट क्युअर नाही म्हणतात, त्याला रॅडिकल क्युअर काय म्हणतात. कोणाही वसईतल्या 1000 डॉक्टरांपैकी कोणालाही रॅडिकल क्युअर कळत नाहीये, आणि त्यांना कळत नाही हे पण त्यांना कळत नाही. ते स्पेलिंग लिहू शकतात पण त्याचा अर्थ नाही माहित. तर आपल्या वसईपुरती एवढा बदल करा की मलेरिया म्हटलं की तुम्ही पहिले त्याला मलेरियामध्ये जंतू 2 प्रकारचे असतात. एक क्लोरोक्विन मरतात, दुसऱ्याला प्रायमॅक्विन लागतं लिव्हर मधल्या जंतूला आणि मेल फिमेलला. तर प्रत्येक मलेरिया डायग्नोज केलं की त्याला क्लोरोक्विन आणि प्रायमॅक्विन किंवा तुम्ही आता जे काही कठीण नावं सांगितले ते म्हणजे आर्टिसोनेट, एसीएस आणि प्रायमॅक्विन. नंतर आणि एखादा ती थेरपी ती रॅशनल नाहीये, ती इरॅशनल आहे म्हणून या देशाचा वाटोळा झालाय. मी तुम्हाला पुढचं सांगत आहे 75 वर्षाचा अभ्यास करून. तुम्ही तो कागद आहे ना तो रॉंग आहे, मी कळवणार आहे गव्हर्नमेंटला. पण गव्हर्नमेंट हा दगड आहे, तो 500 वर्षांनी बदलेल. आपल्या तालुक्यामध्ये आपल्या मनाने करायला पाहिजे. प्रत्येक मलेरियाच्या पेशंटला 10 लोकांना मलेरिया झाला ना मॅडम, तर तुम्हाला 10 पैकी 10 मध्ये मिळतच नाही एमपी. समजा तुम्हाला 6 मध्ये मिळाला तरी 4 गेलेच की नाही. सो डॉक्टरने इलाज हा रोग निदान करून करायचा असतो, रिपोर्टवर नाही करायचा. सरकार रिपोर्टवर इलाज करते म्हणून या देशाचा मलेरिया नाही गेला. सरकारची चूक नाही, सरकार आपलं WHO सांगते ते करते. ते 1.5 शाणे अमेरिकेमध्ये जिथे मलेरियाच होत नाही, त्यांना नाव ठेवून होत नाही. तुम्ही एखाद्या वेळा करू पण नका, पण वसई जर बरं करायचं असेल तर जो कोणी मलेरिया म्हणेल त्यांनी त्याला क्लोरोक्विन आणि प्रायमॅक्विन किंवा एसीई तुम्ही जे सांगता ते आर्टिमिथेसिन वगैरे प्रायव्हेट मध्ये आर्टिमिथेसिन
कॉम्बिनेशन थेरपी. हो सर.
आणि प्रायमॅक्विन. दुसरं
नाही देत
काय म्हणतात
सर, प्रायव्हेट मध्ये देतात,
सगळीकडे देतात मॅडम. 80% लोक प्रायव्हेट मध्येच बरे होतात. सगळीकडे आदर्श ट्रीटमेंट देतात, परंतु आदर्श ट्रीटमेंट चुकीची शिकवलेली हे मी तुम्हाला सांगत आहे. उदाहरणार्थ मिक्स जो आजार आहे ना, मिक्सला त्याला पहिल्या दिवशी फॅल्सिपेरम प्रमाणे म्हणजे प्रायमॅक्विन साठी 14 दिवस जो देतो ना त्याच्या तिप्पट डोस पहिल्या दिवशी प्रायमॅक्विनचा द्यायचा असतो. तुम्हाला हे माहिती असेल, ते कागदामध्ये राहिलं असेल स्लाइड बनवायचं, त्याची काय हरकत नाही. जर तुम्हाला 2 प्रकार या मलेरियाचा आजार असा आहे की मलेरिया इंग्रजीमध्ये शिकवल्या म्हणून कोणाला कळलेला नाही. त्यात 40 शब्द असे जे कोणाला कळत नाहीत, म्हणून आम्ही सेकंड क्लास म्हणून आमच्या देशाचा मलेरिया जात नाही. तर प्रत्येकाला जेव्हा तुम्ही मलेरिया डायग्नोज करा किंवा करू नका, तर केल्यावर तुम्ही तुमचं ठरवा, रक्त तपास करून घ्या कसं आहे, तुमची सगळी अक्कल हुशारी आणि वगैरे वगैरे वापरून किंवा टेस्ट किया हा बायवॅक्स आहे का फॅल्सिपेरम. बायवॅक्स कळला तर तुम्ही त्याला क्लोरोक्विन द्या आणि प्रायमॅक्विन 14 दिवस द्या, 1 किलोला 0.3 मिलीग्राम प्रमाणे रोज. जर फॅल्सिपेरम मिळाला तर त्याच्या तिप्पट डोस 1 दिवस द्या, म्हणजे तिसऱ्या दिवशी. बरोबर, हे झालं 2. जर तुम्हाला कळत नसेल तर मिक्स द्या. मिक्स म्हणजे 14 दिवस वायवॅक 0.25 मिलीग्राम पर किलो प्रमाणे 14 दिवस रोज एकदा प्रायमॅक्विन आणि पहिल्या दिवशी त्याच्या तिप्पट डोस. ही राष्ट्राची नीती आहे, हीच सरकारची नीती आहे, हीच तुमच्या पुस्तकात पण छापलेली आहे. दुर्दैवाने आमच्या मलेरियाला ट्रीटमेंट पाश्चिमात्य किंवा WHO एक्सपर्ट सांगतात, त्यांना हे कळत नाही की 100 लोकांना मलेरिया झाला ते 60चीच तपास होते, त्यातल्या 40 मध्येच मिळते आणि त्यातल्या 30ला ट्रीटमेंट मिळते. त्यामुळे 70% लोकांना प्रायमॅक्विन मिळत नाही. प्रायमॅक्विन दिल्याशिवाय नर मादी मरत नाहीत आणि म्हणून या देशातला मलेरिया 75 वर्ष गेलेला नाही. ही मोठी चूक आहे. मी ही WHO ला कळवलेली आहे, त्यांच्या पुस्तकामध्ये पण ही चूक आहे. मी त्यांचं पुस्तक मराठी आणि हिंदी केलेलं आहे पेडियाट्रिक्सचं, त्याच्यामध्ये ही चूक आहे, मी त्यांना कळवलंही. आता 3ऱ्या आवृत्ती ती दुरुस्त होईल. तर आपल्या पुरतं आपण, आणि मी तुम्हाला काय सांगत आहे की पूर्ण 1500 डॉक्टर जे आहेत, दुसरं काय आहे की सुसंवाद नाही आहे तुमच्या आमच्यामध्ये. तुमच्याकडे आता तुमच्या तपासण्या सांगितल्या नाही 2004-5 वर्षापासून, आम्ही 1500 डॉक्टर आहे की नाही, त्या 1500ची सुविधा नाही मिळत कारण की आमचा सुसंवाद नाही आहे. सुदैवाने तुम्ही आमच्यासोबत आज आल्या म्हणून आम्हाला कळलं तरी. हा सुसंवाद खूप जास्त वेळा पाहिजे. नंबर 2, आम्हाला तुमची अशी मदत पाहिजे की आम्ही दर बुधवारी दुपारी 3 ते 5 इथे असतो आणि गेले 2 वर्ष असतो. आपले नगरपालिकेचे जेवढे लोक दुपारी समजा जेवल्यानंतर पान खाऊन बसतात की नाही 3 ते 5, तर तेव्हा ते रिकामे असतील, तर नसेल तर हरकत नाही, पण ते अटेंड करू शकतात. हे नंबर 1. पण आम्हाला तुमच्याकडनं दर महिन्याला पाहिजे की आमच्या वसई महानगरपालिकेमध्ये आजाराची परिस्थिती या महिन्याची काय आहे. तुम्ही जर आम्हाला सांगितलं ना, अरे 1 कॉलरा झाला तर आम्ही सगळे सावध होऊ. आमच्याकडनं आम्हाला जेव्हा डोक्यात माहिती आहे की जुलाबाचा पेशंट कॉलरा असू शकेल, तर तो म्हणजे वाघ येणार आहे तर वाघ सुटणार नाही, पण आम्ही झोपलेलं आहे की कोल्हेच आहे तर मग आम्ही मरणार.
वाघ आला तर ते वाघ मारे आहेत.
हो. तर हे आज सगळ्यात मोठी चांगली गोष्ट तुम्ही या कार्यक्रमामध्ये आल्या, ही सगळ्यात देव पावला आम्हाला. आणि दर 4थ्या बुधवारी आम्ही हे गावाच्या आजाराबद्दल बोलतो, तर किमान 4थ्या बुधवारी जरूर तुम्ही आमच्याकडे या. आणि तुम्ही हो म्हणता तुमच्याकडनं मी दर महिन्याला रिपोर्ट घेईल की एका महिन्याचा आम्हाला आपल्या आरोग्याची स्थिती काय आपल्याकडे जुलाब किती झाले, टायफॉइड किती झाले, मलेरिया किती झाला.
सर मला अजून एक सांगायचं होतं.
सांगा ना जरूर.
फक्त सर मी
सांगा.
मी तुम्हाला फक्त मला फिशेस माहित असतील जे मलेरियाचे जे लार्वा आहे ते खातात. तर आपल्याकडे सर गप्पी फिशेसचे टँक्स म्हणजे भरपूर 60 टँक्स आहेत टोटल आपल्या वसई विरार मध्ये. आणि जर तुमच्या पण परिसरात असं कोणतं काय म्हणतो आपण त्याला टँक छोटस असं नॉट विहीर किंवा असं हा जिथे वॉटर कलेक्ट आहे बऱ्यापैकी प्रमाणात जे बुजवू शकत नाही आपण तिकडे गप्पी फिशेस टाकू शकतो म्हणजे आपण तिकडे ब्रीडिंग होणार नाही मस्किटोज. तुमच्या अकॉर्डिंगली मी त्या UPSC ला मग सांगेल की तिकडे जाऊन तेवढंच बस.
येस, थँक्यू सो मच स्मिता. गेल्या 2 वर्षापासून मी स्मिताच्या मागे लागलेले की आमच्या कार्यक्रमात ये आणि आम्हाला एक कल्पना दे की मलेरिया प्रिव्हेन्शन करतो आपण. तर थँक्यू व्हेरी मच डॉक्टर स्मिता, तुम्ही आलात. आणि तुम्हाला एवढं सांगायचं की गेल्या आठवड्यात आम्ही मलेरिया पोस्टर कॉम्पिटिशन ठेवलेली आणि त्याच्यात 20 लोकांनी भाग घेतला. त्यापैकी आपले डॉक्टर अनुराधा पालवणकर पण होत्या आणि आपले खूप अशा डॉक्टर्स, स्टाफ नर्सेस आणि त्यांच्या मुलांनी भाग घेतलेला आणि खूप सुंदर असे पोस्टर्स बनवले. ते मी तुमच्याशी शेअर करीन. मलेरियावर एक आम्ही क्विज पण घेतलेला आणि डॉक्टर हेमंत जोशी, अर्चना जोशी आमचे एकदम असे काय म्हणतो वरिष्ठ असे आपले पीडियाट्रिशियन आहेत, त्यांनी पण भाग घेतलेला याच्यात. आणि मलेरिया बद्दल आम्हाला खूप उत्सुकता असते कारण हा एक खूप जुना आजार आणि आपल्याकडे खूप प्रमाणात आहे. गोपाल, आम्हाला
आकडेवारी सांगा ना, सगळ्या एवढ्या मधली मलेरियाची सांगा, दुसऱ्या आजारांची सांगा, मुलांमधल्या आपल्या तालुक्याचा काय स्थिती आहे तुमच्याकडे आकडेवारी असते ना, किंवा काही सांगू शकाल तर सांगा. कम्युनिकेबल डिसीजेस
स्मिता, तुझा आवाज खूप ब्रेक होतोय.
आणि आपला पॅरासा इंडेक्स त्याच्याबद्दल थोडं बोलू शकते सर, पण आपल्याला येतं मॅम.
हो.
सर आपण हे नंतर घेऊया का? आपले थर्ड स्पीकर वेटिंग आहेत.
चालेल.
4:45 झालेत आपले.
ओके, थँक्यू स्मिता मॅडम.
स्मिता, पण पुढच्या महिन्यात परत भेटू.
येस, छान रिव्हिजन झालं मलेरियाचं. थँक्यू जोशी सर. We will move over to our next speaker, Dr. Ankit Gupta sir. He's a pediatric intensivist at Wokat Hospital, Mira Road. Sir is a renowned PICU intensivist. He has done his pediatric critical care training from CMC Vellore. He is managing all critical and complicated cases in our area, around and near in all North Bombay, doing advanced ventilation like HFO, all renal replacement therapies, managing babies which require extracorporeal life support. He's also doing point of care, 2D echo and lung ultrasound. And many of us also got experience of his expertise and know about him. So over to you, Dr. Ankit Gupta sir. He's going to present case of traumatic brain injury. Over to you, sir.
Yeah, thank you, Dr. Gopal. It was an extensive talk by both Smita madam and Joshi sir for malaria. Okay, I hope everybody's awake. I think I was the only one who was sleeping before. I'll also have to be awake. Okay.
All of us are awake, wide awake.
You were sleeping during my this thing.
Yeah.
Ankit, now don't sleep.
Yeah.
During your talk.
I am going to snore very loudly during your.
Okay. Barod sir's voice also I can hear.
Okay. That was slip of tongue.
Okay. Okay, so I'll be talking about this head injury or this traumatic brain injury. Okay, and we'll keep it interactive so that nobody sleeps in my session. Other sessions you can sleep. My session you cannot sleep. Okay. Okay, so we'll discuss the case that we had, and she was discharged a couple of months back, and some data about traumatic brain injury and how to manage. Okay, so this was the 6-year-old girl. She was riding a bicycle on her on her parapet or podium, and along with the bicycle she fell, and it was around 10 to 12 feet. With the bicycle she fell. She had fallen around 30 minutes back or so. She had a transient loss of consciousness for around 3 to 4 minutes only. Okay, and then again she got up. Again she became drowsy for some time, and she got up, and they took to some hospital. Then from that hospital they sent the child here. Okay, can you see my cursor?
No.
No.
So we can't see your cursor.
Okay, fine. Okay. And she was sent here. So on examination, she was drowsy, and again she was crying intermittently. Mummy, mummy, she was crying, and again she was going to sleep. Okay. GCS was around 9/15, and slowly we felt that the GCS was dropping what it was an hour back. Okay. And her vitals, pulse was around 120 per minute. Respiratory rate was 20 per minute. Blood pressure was 104/70, and SATs were 98% on the room air. The other injury that she had, because she's fallen from such a great height, is she had few abrasions on her right foot. So anybody, like, what will you all do next?
This child is quite bad. 9/15 is a very low GCS, and if it further, we'll have to be perhaps intubated because.
Yeah, maybe. Yeah, that is what madam has told us, right? You'll intubate the child. Okay. Huh? So many a times what happens is we immediately do a CT scan. Okay. So don't rush towards CT or MRI. First, you need to stabilize the child. Okay. Airway always comes first. So you first stabilize the child, only then you go for CT. Okay. Because if you have not stabilized the child and immediately you have taken for CT, your child may cone in the CT room. Okay. We don't want that to happen. She may require intubation, and she may require some bolus also. Okay. So we intubated the child, connected her on the ventilator, gave her one bolus. Heart rate was slightly high. Okay. And what CT do you all want? You want a plain or you want a contrast CT?
Plain.
Yeah, we want a plain CT. Okay. We don't want to waste time. Contrast does not yield much information. In a head injury, we just want to see whether there is any bleed or not. Okay. So we did a plain CT, and we did her USG rapid E-fast. We have done. We saw there was no pericardial effusion, no free fluid in the abdomen or in the bladder. Everything, all those things were fine.
What is neuroventilation?
Neuroventilation is basic ventilation, where you keep normal PEEP, normal 6 ml per kg tidal volume, all physiological rate, minimum FiO2. Okay, so all the basic ventilation that is needed. Nothing, we don't need to do a ARDS, like you don't need high PEEP and all those things. So all the basic ventilation we have done.
Okay.
So we did a CT here. Okay, and see, you can see. So now I think this would be. Is it visible to you all?
Yeah.
My pointer.
Yeah.
So you see there is a small SDH that is there. Okay. And we are not radiologists, but we should know some few basics of CT. So something that is missing over here is, see this. These are the ventricles. Yeah, the ventricles are getting kinked. Okay, ventricles are getting kinked. The gray-white differentiation is also going. Okay. This is only half an hour or 1 hour after the injury. Okay. Yeah, this parieto-occipital bone, where it is, I also don't know where it is fractured. The radiologist has told. Okay, but you can see. Yeah, Dr. Kant is telling something.
Yeah, can I ask a question?
Yeah, you can ask.
I mean, I can't see it very well, but would you call it an SDH or an EDH?
It is a SDH, subdural. Okay.
Both senior doctors, we are very poor in memory and English and short forms.
Subdural
hemorrhage
and epidural.
Please use so that
subdural
we don't even 30%. We pass with 30%,
but it looks like bilenticular shape. It's like a leg.
Yeah, I agree with what Dr. Kant is telling. So because there are small contusions over there, and we have the previous CT. It could be a EDH also, but I don't know. The radiologist has told us subdural hemorrhage. Okay, what he is telling is correct. It is the bilenticular. This thing is bilenticular. We'll come to the differentiation between SDH and EDH in my next few slides. Okay. So based on this CT scan, so you all want to operate the case cheese. This means all these things, the ventricles are getting kinked, the gray white differentiation is gone, this small hemorrhage is there. Okay. So anybody wants to operate, you all want to try medical management first?
Medical
management.
Very good. So we also did medical management first. Okay. And simultaneously you have to continuously monitor the
If you're thinking of EDH, extradural, then you will want to operate immediately.
Yeah, EDH, I would want to operate.
You will want to put a pressure gauge in the brain so that you can keep monitoring the brain pressure. There also seems to be a slight midline shift of Ankit to the other side.
So it was a small midline shift which was less than 5 mm. Okay, and we had not given her any anti-edema measures.
Which goes with the extradural rather than
extradural hemorrhage we have to monitor. I think my radiologist gave this a subdural hemorrhage, a small subdural hemorrhage. Okay, so currently we had not given her any anti-edema measures. That's why we thought of conserving the child. Okay, some neurosurgeons may say you can operate on the first CT itself. Depends from neurosurgeon to neurosurgeon. Our neurosurgeon told, okay, we'll see and we'll monitor the child. Okay. We monitored the child and she again, she started to deteriorate. Okay. She started intermittent posturing. She started throwing seizures. She had decorticate posturing. Pupils were still equal. So all these, despite we giving her all the anti-edema measures and anti-epileptics. Okay. So now coming to the next CT. So this was the CT and this was us. Okay. So extensive contusions are there. Multiple parenchymal contusions are there. Okay, that we see in the cortex and in the subcortical region. Okay, you see the ventricles. You cannot see the ventricles at all. The ventricles have disappeared. There are no ventricles. Okay, midline shift is also seen here. The sulci gyri are also gone. Lot of mass effect is seen over here. If you see, this whole thing is compressing. Okay. So patient was taken for immediate decompressive craniectomy. So decompression was done. This is post decompression. We did a CT. You see adequate decompression. The surgeon has done a bifrontal decompression. Here he has removed the frontal calvarium, and you see the brain over here. Again, the ventricles have started to appear. If you see here, that were kinked. Okay, they have opened up. You see the mass effect has also decreased. If you compare this CT with the previous CT, the mass effect has decreased. Okay, so we were happy, everything was going smooth sailing. Now, yeah, day 3 she was clinically better. She started opening her eyes. She was obeying commands. We extubated her. Okay, we started de-intensification, means we started decreasing all her supports. We started decreasing the anti-edema measures. By day 5, we started to mobilize her, and we planned to. She started to take feeds also orally. Okay, and we planned to shift her out for the next day. Okay, so next day again we were like this. So on day 7, again her GCS started to drop. We had decreased her anti-edema measures. She started throwing seizures. Baby required re-intubation. Again, all supports, hypertonic saline mannitol, all those things were to maximum. So now what do you all want to do?
Repeat a CT.
Yeah, repeat a CT. We did an MR. So you can see the brain. This is the defect that is there. So it is herniating from here, and you see this. The brain has become a fountain like this. It is herniating. We could feel the brain. It was the scalp had become so tense.
Did they have a manometer in the brain at that point?
No, we didn't have. We were not monitoring her ICP. Okay. So it had become so tense, and it is protruding out. Just like this. Okay. There was midline shift also, you can see. And significant cerebral edema was there. Also, infarcts are also there. A lot of hyperintensities are here. So now patient again deteriorating, not a good thing. So relatives took second opinion, third opinion, nth opinion. Neurosurgeons also had come. They came and they saw the child. So some people advise that we should, what would you all do? Some people advise we should widen this. Okay, widen the craniectomy, the surgeon. But our surgeon was against this. We decided to conserve the child. He told he was quite confident that this will come back to normal. This herniated brain will again go back inside. The reason he gave was lot of scalp edema was there already. She had undergone one surgery. It will be again difficult to do a redo surgery for her. Okay. So we decided to conserve the child. We started her on thiopentone coma. So after starting her on thiopentone coma, she started improving after 3 to 4 days. She started localizing. Signs of ICP decreased, and she was extubated on day 12. Physiotherapy, occupational therapy, all those things were continued. Baby did have so much of frontal lobe infarct, so baby had behavioral issues. And then we discharged her on 21st day. Okay. So this was the case that we had. I'll just go through some literature quickly about TBI. Okay. The global incidence is somewhere between 52 to 50. Males are more commonly seen, and it is basically in infancy, bimodal distribution in infancy and in adolescence. Infants keep walking, they keep falling here and there. Okay. The Indian scenario, I'll come to the important points. So infants, non-accidental trauma is quite common. Toddlers, again, non-accidental trauma and falls are common. School going, they play various sports, and through RTAs, they get this injury. Adolescents, RTAs and assaults, high-risk behavior. So this is how it's common. So now coming to road traffic accident, sorry, okay. Road traffic accident. Okay. Road traffic accident and assaults. Okay. Now, this is very important. Grading of TBI. What is the severity of TBI? Okay. And so if your GCS is 13/15, it is mild. This will help you to prognosticate. Okay. So whenever you are attending a child who has had a head injury and his GCS is around 10/15 or 9/15, you have to tell the child, tell the parent that it is a moderate form of TBI. Child can become sick. Okay. And severe is less than 9. So this grading is very important. Okay. Also, you have to tell at the same time that we saw how the child deteriorated. That TBI is an evolving process. The brain injury is going to evolve over the next 72 hours or so. Many times relatives will tell you, पहले CT में तो नहीं था, अभी कैसे हो गया, आपने treatment नहीं किया, गलत treatment किया, कम किया, ज़्यादा किया, all these things. So you have to tell that things are going to get worsen before they improve. Okay. All this counseling is important. So, what are the types of brain injury? One is focal, एक ही जगह पे लगा है. The other one is diffuse. Okay, contusion, laceration, hemorrhage, epidural, subdural, intracerebral, and subarachnoid. I'll show you the pics in the next few slides. Okay, and diffuse is concussion. Concussion can be mild concussion or severe. Other thing is diffuse axonal injury. One thing you have to remember about diffuse axonal injury is your CT will be normal. Initial CT will be normal, but your patient will be comatose. Okay. This is how you differentiate between diffuse axonal injury. So in those cases, your child will need an MRI. Okay. Now coming to Dr. Khan's question, epidural hematoma versus the subdural hematoma. Okay. So epidural mostly is an arterial bleed over here. In infants, you can get a venous bleed. Okay. Here it is an arterial bleed. There will be a lucid interval. Okay. Because it is from the middle meningeal artery. The thing that is coming from the bone, middle meningeal artery is coming. So it is an arterial bleed. Here, subdural hematoma, slowly, veins will start filling up. You will see the CT images here. Okay. So here, this is how it is. And this is a subdural hematoma. Okay. Very difficult to distinguish on that CT because it was a very small EDH bar SDH. Okay.
Yeah, but that biconvex thing
is there. Also. Even if you see the SDH, if it is a small SDH, it will be very difficult to make out. That's why we did repeated this thing.
CT.
Yeah. Okay. So this thing, EDH is from the middle meningeal artery. You will get a lucid interval. Okay. I think Joshi madam's patient had come with the EDH over here.
Yes,
And
yes.
the child was talking, the relatives were not willing to undergo surgery. And then slowly after 2 hours, child just started to deteriorate, GCS started dropping. Okay. It is very difficult to counsel the relatives over here that the child needs emergency surgery. Again, coming to other is diffuse axonal injury. So in diffuse axonal injury, see, this is the white matter of the brain. This is the gray matter. Okay. So whenever there are shearing forces between this part of the brain and this part of the brain, this part contains axons and this part contains the bodies. Okay. So what happens is, you see over here, whenever the head bangs, so this part travels in a different speed compared to this part. So they break over here. Okay. Shearing forces that are there at the interface over here. So the axons break. And here, you at the most, you will get small petechial hemorrhages in the CT, or your CT will be normal, but your child will be comatose. Okay. So you will need an MRI. Don't go and jump immediately and do an MRI. Just keep at the back of your mind. This will help in counseling the relatives. Relatives will tell her, yes, ma'am.
How is this different from a concussion? Because how will we?
Concussion will be localized, छोटा सा ही रहता है. Again, CT concussion, if it is a mild concussion, nothing, your brain's GCS, everything will be normal. Okay. Here your GCS will not be normal. Concussion is just a small hemorrhage, छोटे से जगह पे चोट लग गया, or a bruise type of thing. Okay.
Okay.
Okay. Yeah. So that is a concussion. Diffuse axonal injury, it is widespread all throughout the brain parenchyma. And if you are having, if your MR is showing diffuse axonal injury ka signs in your brain stem, then it carries a poor prognosis. Okay. Okay. Now, mechanism of injury. So this is very important because we have to prevent secondary injury. Primary injury is directly how the whatever accident or whatever has happened, direct impact that is there on the brain parenchyma. That is the primary injury. Secondary injury is all those things that we prevent that और ज़्यादा खराब होने से बचता है. Okay. This will about your prognosis. This tells about your prognosis. So you have to maintain everything. You have to maintain normal oxygen, temperature, intracranial pressure, blood pressure, anemia, all those things you have to maintain properly. We will see that in the treatment. Okay. These things cause secondary brain injury: hypoxia, hyperthermia, intracranial hypertension, anemia, vasospasm, mass effect, hypotension, hyperglycemia, very important, both hyper and hypoglycemia, CO2 more or less CO2, cerebral edema, seizures. So yes, these are treatable conditions. This we cannot treat. This has already happened. So we have to prevent all these things. So our treatment mainly focuses on this. Now these are the guidelines that are there. Pediatric traumatic brain injury, 2019 guidelines are there. Level 1, good, strong evidence. Level 3, weak. Level 2 means okay, moderate evidence. Okay. So always first, don't go and jump in the MRI, in the CT room. Don't send your patient. Always stabilize the patient first. Okay. Airway, breathing, and circulation. Okay. So all these things are very important. What are the indications for injury, for intubation in a child who has got head injury? Okay. People come to me saying saturation, Ankit, saturation 99% hai, kya karu, but bachchi ka GCS 8/15 hai. Obviously, you have to intubate the child. Okay. So if there is upper airway obstruction, okay, like this loss of pharyngeal muscle activity and tone, if there is some ear, if there is a injury over here on the trachea or on your windpipe, direct trauma, if the child is continuously throwing seizures, baby is in status epilepticus. Okay. If the child is having abnormal breathing, chest wall dysfunction हो गया है, flail chest हो गया है, okay, aspiration हो गया है, cervical spine injury, patient is not breathing properly, patient is unable to maintain the gas exchange, PaCO2 is rising, so all these things will cause secondary brain injury. So ये अपने को prevent करना है. Okay, CO2 more than 45, pupils more than 1 millimeter difference. Okay, you have to intubate the child. Any GCS less than 9 needs intubation. Okay. Or if your GCS was 12 before, now it has become 10. Fall in GCS. Okay. Fall in GCS of more than 3, irrespective of the initial GCS. GCS is falling means child needs intubation. This is very important for the primary pediatrician. You guys will be attending this. So you all should know. Now, every child who has had a head injury, you have to suspect that the child has got injury to the cervical spine. Okay. So every time you have to do that. You should avoid head tilt and chin lift maneuver while intubating. So head ekdam aisa karke, just we don't have to, kapda nahi banana hai iska. So the neck, or else if you hyperextension, all those things happen, there will be injury to the cervical spine. So you have to assume that the child has got cervical spine injury, and you have to take all precautions. This hard collar should be there. You have to stabilize. Okay, only jaw thrust. See how he's keeping his fingers over here, and you have to push it up. Okay, inline stabilization is there. I'll show you in the next slide. Okay,
Dr. Ankit, can I make a comment at this point?
Yeah.
Sorry. So cervical spine, there are 2 ways to go about it. If you have a surgeon who is willing to clear your cervical spine, they can do that. But the only caveat is that it's not allowed if there is a distracting painful injury. So if there is like a very big hand or limb injury, so if there is a severe distracting pain in the child, and if the child can respond to command, but the pain is so severe that the child cannot focus on the cervical spine, so better not to clear the cervical spine. So because you will get a lot of adolescents also.
Yeah.
You will not know whether to clear or not to clear. So if you got a surgeon who can clear the spine, as long as there is no other distracting injury, or you give a good backing dose of analgesia, and then you can clear the cervical spine. So, but other than that, so cervical spine has to be assumed that it's involved.
Yes, that is what Dr. Kant. So we have to assume that the cervical spine is involved, and you have to take all precautions while intubating the child. Sometimes your child may be comatose, he may not be moving. Such could be the impact of injury. So you will think, okay, ye to hil hi nahi raha hai, he doesn't need drugs, he doesn't need inducing agents for intubation, but that is wrong. Okay, they will perceive pain. Again, pain will lead to rise in ICP. He may have tachycardia and all those things. So you have to give neuromuscular blockade. You have to suppress all those reflexes. Okay. So the next slide is here. You do how you do jaw thrust. Your other attendant will come here. This is manual cervical spine stabilization. Okay, how he is doing. Okay, and this fellow is intubating. Do not hyperextend. Okay. Okay, this is very important. Many times we are able to save the brain, but then the spinal cord goes and the child is paraplegic. It is a very sad state of affairs. Now, coming to breathing, hypoxia should not be there. All these things cause secondary injury. Okay, hypoxia, your saturation should be more than 94. 100 is not necessary. 94 to 98. Okay. So saturation के साथ CO2 भी देखना है, not only oxygen. Okay, एक blood gas is important. Also, people may think that why is the child who has got a head injury, why is he having why are the sats low? So he may have a neurogenic pulmonary edema, or the lung must have been injured. So sats are very important. Neurogenic pulmonary edema, what happens whenever there is a head injury? Lot of catecholamines are released. Okay, lot of catecholamines are released. So they cause cardiopulmonary dysfunction. Okay, so that is the cause of neurogenic pulmonary edema. I hope I'm making sense. Okay, and when you intubate, you put him on the ventilator, you avoid high PEEP. Okay, so if you're giving too much PEEP that exceeds 9 or 10 centimeters, so again your intrathoracic pressure will rise. Again, that will be transmitted to the brain, so it will cause raised ICP. Okay, maintain a normal pH 7.3 to 7.4 and a normal CO2 along with your normal oxygen. CO2 around 35 to 40. Okay. Circulation has to be checked. Patient may be losing blood for some point, so you have to give replace the blood, and always use isotonic fluids. Do not give bolus of DNS or do not give bolus of ISOP. It's very common. always use normal saline or plasma light, balance all solutions. If the child is hypotensive, do not give DNS bolus or ISOP bolus. Hypotensive episodes, again, they increase the mortality. You try and maintain the cerebral perfusion pressure. In the next few slides, I'll talk about what is cerebral perfusion pressure. More than 40, at least you have to maintain. Suppose you cannot monitor the cerebral perfusion pressure at your place, you have to maintain the normal mean arterial pressure. Okay. So the simple formula for mean arterial pressure is, everybody knows, the 55 plus 1.5 into age is the rough formula for mean arterial pressure. Okay. Suppose you don't know this, at least maintain the normal systolic pressure. Okay. Systolic pressure, everybody knows. Vaishali madam has distributed a lot of pamphlets and we have had a lot of CMEs on hypertension. Okay. So maintain the normal map, mean arterial pressure. GCS, pupil size has to be checked regularly. Both you maintain the sugars between 100 to 200. Both hypoglycemia and hyperglycemia are detrimental. You see if the child has any neuro deficits. Okay. Maintain normothermia. Okay, check for any other external injuries or other injuries that are there. Neuroimaging, I'll go quickly because I think I'm running out of time. X-ray, you generally, nobody is doing X-ray skull and all those things these days. X-ray, if you want to do of the chest X-ray, to see if the child has pneumothorax. Okay. And CT also, sometimes child will, kisme nahi karna is very important. Okay. Because for every 1000 CT that we are doing, we are giving one cancer to the child. Okay. Especially in the early age group. So when not to do is very important. Everybody knows CT karna hai, plain karna hai. Many times the mother will bring bachcha bed pe se gir gaya and gachakla hota. Asa gachakla hota, 1 minute gachakla hota and ek baar vomit kela. Immediately patkan CT karun gaya, patkan. Asa nahi karaycha. Okay. Okay. So CT, yeah, see. So one every 1000 or every 5000 CTs we order, we give them one cancer. Okay, this is what we have to. So I must have given at least 5 to 10 cancers. I don't know about your. So this is especially if it is in the earlier age group. Okay, so that's why CT scan has to be judiciously used. So many scores are there who will require CT, who will not require CT. I'll just tell you who requires CT. So if there is loss of, this is very important because we are the one who order it on phone. Okay, loss of consciousness for more than 5 minutes. 1 minute ke liye gachakla hota, asa kela hota, tasa kela hota, kahin nahi. Okay, just observe the child for 5-6 hours, he'll be fine. Okay, or if the very difficult, if the child has amnesia for 5 minutes duration difficult. If the child is drowsy, obviously you have to go. One time vomit you can just ignore. Okay, here 3 or more vomiting. And whenever you are writing on your OPD sheet, observe, mention it, that child needs observation for 5 to 6 hours. Okay, you have to mention if it is just one episode of gachakla, because then a lot of medical legal issues are there. Aapne CT kyun nahi karaya, ye nahi karaya, abhi jaake aage bad ho gaya. So you can say you have evidence to support. I had told for observation. If needed, later on we'll do. Okay. If a child, if you have observed for 6 to 8 hours and the child has not deteriorated, most likely he is not going to deteriorate further. Okay. This is what we
apologize.
Yeah.
Apologies. The lucid interval typically is 24 hours for an EDS. So what I advise all my patients who would come with all this, some vomiting or some query LOC kind of what you're saying, where we don't do a CT, or even if we have done a CT that doesn't really exclude everything, the best thing to tell them is that the child needs to be under constant observation for 24 hours. You do not let them out of sight for 24 hours.
Yeah, child needs observation for 24 hours, but it is these are guidelines, and you tell them we will be monitoring you. Okay, if he is deteriorating, then we'll do a CT. If he has not deteriorated, loss of consciousness is very minimal. Only one time he has vomited, it can just be a same concussions, which doesn't need a CT. Because every time, as I told you, every 1000 CTs we are doing, we are giving them one cancer. Okay, especially bone marrow cancer.
I'm saying we don't want CT, and hence the observation should be for 24 hours. That's what I'm saying.
that's okay. The studies have shown that if nothing has happened to the child for 6 to 8 hours, most probably nothing is going to happen. Okay. So if the GCS also, you see all these things, huh? If the GCS is even 14, you get a CT done. Okay. Or if the child is having a penetrating or a depressed skull injury, ens fontanelle or your base of skull fracture, like this thing, your raccoon eyes or your battle sign that are there behind the mastoid. So the child warrants a CT scan. Bruising, swelling, or laceration that is more than 5 centimeters, child needs a CT. If it is this mode of injury is very important. High speed accident, more than 40 miles they have written. These are the US guys. So if it is a high speed accident or a pedestrian cyclist, then you have to get a CT. Fall from more than 3 meters, okay, is very significant. Chota sa bed hai, chalte chalte gir gaya, gachak gaya, asa chala, it's okay. Many times infants come to us, he was walking and he fell down and he started to cry. Okay. If he's all right, GCS is okay, I would not advise us. Okay. Then role of MRI, I already told you, for diffuse axonal injury and also to see the extent, but after stabilization of the child. Okay. After 48 to 72 hours, you can do a MR. Neuroimaging, yeah. Early, if your early CT scan is, this is very important for counseling. Patient will again, as I had already mentioned, कि अभी तो नहीं था, बाद में कैसे हो गया? So you have to tell them कि early CT can be normal. The injury evolves over 72 hours at least. Okay. Huh? So early CT scan should not be used to rule out raised ICP. Very criteria are there that help in prognostication. Rotterdam criteria is one such. Generally by radiologists, but we should know the components. Okay, this will help you prognosticate the child. If your initial CT is showing compressed or absent basal systems, midline shift of more than 5 mm, 1 or 2, 3 mm is okay. More than 5 mm, okay. Some epidural mass present, intraventricular hemorrhage is there. Okay, so all these are warning signs. You have to tell them, see, boss, this is a bad thing and child can deteriorate further. Okay. Scoring, various scoring systems are there. I'll not go into much detail. Just coming to management. So whatever we are doing is we are doing ICP monitoring, ICP and CPP targeted therapy we are doing. Okay. The various places where you can all over the brain, whatever is there, you can put the intracranial pressure monitoring system. This is the brain parenchyma. You can put an intraparenchymal one. In the epidural space, you can put in the ventricle, you can put in the subarachnoid space. Amongst this is good because whenever the ICP rises, so you can open this, CSF will drain and this will decrease the ICP. Okay, this is quite okay. Now CPP targeted therapy, what I was telling. CPP is cerebral perfusion pressure, MAP is mean arterial pressure, and this is ICP. So in very simple words, what is the cerebral perfusion pressure? Whatever arteries that are there that are going inside, whatever pressure that is there inside them minus the intracranial pressure. Okay, this is, I hope everybody understood. So all therapies are targeted towards CPP targeted therapies or ICP targeted therapies. Just remember few values. ICP value is 20 and CPP value is 40. Okay. So more than 20 for more than 5 minutes, if you're monitoring ICP, that needs to be treated. Okay. It is, so even the means that intracranial pressure rising for more than 5 minutes, the mortality, it increases the mortality. That is why we have come with ICP targeted therapies. Okay. CPP, more than 40, you have to keep at all times. Okay. Suppose you cannot monitor all these things. Patient is in your care, in your nursing home. Patient is drowsy, at least maintain a normal mean arterial pressure or a normal blood pressure for that child. Okay. Advanced neuromonitoring I'll skip. Then coming to hyperosmotic therapies. So a lot of studies are being done between hypertonic saline and mannitol. Hypertonic saline is always preferable over mannitol. You give as a bolus of 5 ml per kg. Okay. Maintain high sodium. How much high? Around 145 to 155 you have to maintain. Do not go overboard. Do not go to more than 160 or more than 170. If you go 160 to 170, your child may have DVT, thrombocytopenias, and all those things. Okay. So maintain 145 to 155 sodium by your boluses of hypertonic saline or your hypertonic saline infusion. This thing 23% hypertonic saline has come. I have also not used. I don't know whether it is available or not. The good point is the dose is lesser, 0.5 ml per kg. Okay, and so you will require lower volumes. Okay. Now sedation analgesia. People will say, oh, bacha to comatose hai. He doesn't need sedation analgesia. That is not the case. They may feel pain. Again, the ICP may rise. Okay, so you have to give sedation and you have to give analgesia. A lot of concerns were there regarding ketamine, that okay, ketamine will increase the intracranial pressure, nothing like that. Ketamine increases the mean arterial pressure also. Okay, so the intracranial pressure is maintained. It does not cause raised ICP. Okay, these are the latest studies. So ketamine is a very good drug you can give for intubating the child. It does not cause respiratory depression. Sometimes whenever you're giving a drug for intubation, you may feel, "Arey, bacha saas nahi liya to kya?" Huh? So ketamine does not cause respiratory depression. So you give 1 milligram per kg or 2 milligram per kg, and you can intubate the child easily. Okay. Neuromuscular blockade, depending upon the patient to patient, we use neuromuscular blockade. Sometimes they have shivering. If the patient has shivering, again there will be raised ICP. If the patient is breathing and the ventilator, if he's fighting with the ventilator, again there will be raised ICP. So for synchronous patient ventilator interaction, we use neuromuscular blockade. External CSF drainage, if you put the EVD inside, if you have a EVD or if your ICP monitor is inside the ventricles, you can use this whenever the ICP increases, you can drain CSF. Prophylactic AEDs, prophylactic anticonvulsants. So all studies were done with phenytoin. Okay, we can use Levera very safely, nothing, no issues. You can use Levera, but you have to remember it will only prevent early post-traumatic seizures. Okay, it does not have any effect on late post-traumatic seizures. Okay, so if you're having a child with severe traumatic brain injury, so you have to give him anticonvulsants. Okay, patient will tell, आपने तो दिया था, फिर भी fits आ रहे हैं 2 हफ्ते बाद. You have to tell him, if fits आ सकते हैं, ये सिर्फ पहले 1 हफ्ते में prevent करता है. Okay. Then decompressive craniectomy and barbiturates. Okay. So pentobarbital, generally this is, we use it after you have failed all your medical management, which I used in this case. You have failed medical management, you have failed your decompressive craniectomy. This is high dose barbiturate or pentobarbital coma comes after that. Okay, after failure of surgical management and your medical management. This is the last Brahmastra that is there in our armamentarium, and we use it. So decompressive craniectomy, it is very simple for us to say कि इधर से निकल जाएगा. I also do not know much of the steps. We just say कि यहाँ से skull निकाल देंगे and पहुंचा देंगे. These are some of the steps which I am not aware of. Okay. Okay. They raise the flap like this, and again maybe I don't know if Dr. Kant knows the steps. I think he has gone off to sleep. He's not asking me questions anymore.
No. I got a phone call. What did you say?
No, you know the decompressive craniectomy steps? क्या कुछ पता है? Generally they raise the bone flap. Okay.
Yeah, so the bone can be done in 2 ways. It can be just disconnected on all 4 sides and kept inside, or it can be kept in the freezer also. It can be just removed completely. So posterior fossa, they usually completely ढक्कन निकाल देते हैं and side में रख देते हैं. And so I think in this case also they have removed it completely and
so they have removed the frontal part of it.
I did not see the anterior skull bones were not seen. So they've removed it completely. They just covered it with mesh if required, and just the skull, and later on they'll put it back.
So just exactly what he told. So they completely remove the bone that is there, and they put some gel foam or something, and they suture it. This patient, we have replaced it. She came last month for this frontal bone was again replaced. Okay, this part was removed. It was again replaced. This is the replaced 3D reconstruction. Okay, Nutrition, yes, you have to give all your child. There is no contraindication for nutrition. You have to start them off on feeds. If you don't start feeds for them, your child may not die of traumatic brain injury, but may die of gram-negative sepsis from translocation. Okay, steroids do not have any role. Okay, a lot of us have the habit of giving steroids. Generally, do not have any much role. Okay, so take-home message: you maintain the ICP more than 20. Okay, you optimize the neuromuscular blockade, you give all your mannitol, hypertonic saline, you maintain normal CO2 or CO2s of 30 to 35. Then if it is failing, you go for hypothermia. Studies are not many studies are there for hypothermia. We had used in this child. You go for barbiturate therapy when all these things, your decompressive cranectomy has failed, you go for hypothermia and you go for barbiturate therapy. Okay. And this is the girl that is there. Okay. On discharge, she is there. She is doing well. Okay. And again, this is maybe this is me, and this is.
Okay, this is the same child we sent from Virar.
No, ma'am. This is different child. Your child is doing. He is a different child. This is from Mira Road only. This girl is from Mira Road.
That's you, Ankit, doing that circus in the water?
What? No, ma'am. No. This is just from internet. I have taken this picture.
Yeah.
Ankit sir,
He's Iron Man.
Sankhya sir wants your presentation.
So yeah, we'll give him the presentation. No
Yes,
issues.
yes.
Okay. Super.
Thank you very much.
Thank you.
For deliberate talk. Any questions?
No,
Very well managed.
Very well.
Very well managed.
Dr. Kant, only your photo is talking. I cannot see you.
He's sleeping.
Yeah.
I didn't want you to catch me sleeping, I'm just relaxing at home, nothing better to do because the event is cancelled. So,
so it was wonderful, Dr. Ankit. What a marathon run for 21 days. That was really fantastic. Lots
pretty
of
fast, madam, actually. 21 days is quite fast, I would say.
yes. And with the
Because they kept on.
No, the replacement was done
other.
later on after 2-3 months. It was not immediate replacement. It is after 2-3 months the surgeon replaces the bone flap again.
And the girl is normal?
Yeah. That is her photo only, real photo. Yeah.
Super, very well managed. And we had a lovely, after a long time, we are seeing cases and they were wonderful. So thank you, Ankit, and thank you, Kant. They were really lovely.
Thank you, Kant. Thank you, Ankit. Thank you, Smita. She's not there.
Thank you, Gopal. Thank you.
Thank you, Gopal, for a wonderful moderation.
Thank you.
Yes.
Angelique.
आणि ब्रह्मास्त्र म्हटल्यावर गोपाळला अगदीच असं आनंद झाला.
Thiopental stock करा.
So
nobody has it these days. Very difficult to find thiopental.
Thiopental?
Yeah, it's very difficult to find because the anesthetists have stopped using it.
So all the difficult to find things are at Wockhardt.
Yes.
Because all the difficult to manage cases are at Wockhardt. All the medical.
Gupta sir is also at Wockhardt.
Yeah.
Difficult thing to find.
Yeah. So, Vaibhavi, काय बोलायचंय?
No, we had a wonderful case discussion today after a long time. Yeah. I hope next month also we have our monthly CME.
So, and happy Doctor's Day to everyone in advance. And we will be having a nice webinar next Wednesday too. We'll be soon declaring the subject. And do join us next week for the webinar as well. And Ankit and Kant, like you participated today, you can come for all our webinars and participate.
Yes, I would love to.
Yeah, but I'm sure this Ankit's case was also a medical surgical case, so that interested you. Just a medical case may not. So,
I just wanted to be there and fall asleep.
He's not listening to you. He's on the phone.
Yeah, he's run away now.
Yeah. Yeah, Gopal, thank you very much. Archana,
Thank you, Gopal.
अर्चनाला काहीतरी
Hi,
बोलायचं.
all the girls on the webinar. Just wanted to tell you there is a Femi Pedicon at Nashik. So do register for that.
कधी आहे?
30th and 31st July, and they have made arrangements in the university campus. And our Vice Chancellor, Dr. Madhuri Kanetkar, is the in charge of that.
And there will be an entertainment program for accompanying spouses.
Okay.
So do register.
Yeah, great.
I put it on the group. I'll again post it.
Yeah, repost it. Yeah. Okay, Archana. Thank you so much, Ankit. Thank you so much, Kant. Thank you so much, Gopal. And thank you everyone who are still awake on this webinar.
Thank you everyone. Yeah.
Attentively
Thank you.
listening.
Thank you,
And Dr. Hemantला काहीतरी बोलायचं.
ते ना स्मिता नाव होतं ना त्यांचं.
हो, स्मिता वाघमारे.
त्याच्याकडे दर महिन्याला एपिडेमिओलॉजी घ्यायला पाहिजे.
हो हो.
आपण last month.
No, I'll invite her. It was so difficult to get her this time, but even now she was attending when there was some other conference going on. So we'll get again.
Mokar lab gives us cultures. Everything at Barods Hospital and my hospital and many places. So I have talked their microbiologist and Dr. Mrs. Mokar. His thesis was on blood culture in sepsis, childhood sepsis. He is good at that. So they are going to present their their advice
data.
Their advice to us pediatricians next Wednesday.
Okay.
म्हणजे लास्ट आपल्या CME मध्ये ते एक
last in the
monthly CME.
आणि असं सगळ्या आपल्या घ्यायला पाहिजे.
हो हो. Yeah, that will be very nice.
Yeah, please include them next.
Yeah.
आणि एकदा तुझ्या अंजली तुझ्याशी फ्री वेळ असला की WhatsApp वर व्हिडिओ कॉल करेल.
चालेल.
म्हणजे सुहासचं दर्शन तर भेटेल.
चालेल. I'll do that.
Suhash is okay. Suhash is okay, na?
Ekdam fine. Okay, friends. Bye.
Bye everyone.
Bye Gopal. Thank you so much. Bye everyone. Bye Kant. Bye Ankit. Bye Anuradha. Bye Archana Hemant. Bye.
Bye Anjali.
Bye.
We have to.
तू आता याने शिकवतो. दोघे युनिव्हर्सिटी पास आहेत का काय ते कॉम्प्युटरचं दोघे पुढे या उभ्या राहा.
5:30 झाले. लेट होऊन मला परत.
इकडे बघा.